I would like to welcome you all to the American Health Quality Association Physician Leadership Network Clinical Discussions webinar series. Today's presentation is titled Everyone with Diabetes Counts, a QIO-led project to affect behavioral change and improve outcomes. Your host today is Dr. Adrienne Mims. Your facilitator is Dr. Natalie Tappy, and presenters Janice Hidalgo, Brenda Ortiz, and Artis Reed. And now, without further ado, I'd like to turn things over to your host, Dr. Adrienne Mims.
So glad that you're able to join us today for this webinar. We are all in preparation for the work that we go working with Medicare beneficiaries and the public moving forward into the future. And we're so glad that you're able to join us here today to discuss this. We are part of the AHQA, the American Health Quality Association, and we have developed this learning series as a way to prepare the whole quality improvement network of individuals throughout the country for work that will help improve the CMS quality strategy. We do have a website that actually hosts all of our prior presentations and will include this one today. We feel that it's important that we collaborate and share best practices. One of the terms we use is sharing shamelessly. So today, I'm very proud to bring forth to you several people from around the QIO community who are going to present to you information about Everyone with Diabetes Counts. I'm getting a question if someone's not hearing sound, but I'm assuming that most of you are able to hear me. First, I'd like to present to you Natalie Tappy, who is a nurse, and she leads the project with Everyone with Diabetes Counts in West Virginia. She has been there for more than 15 years, offering her expertise in this area. We're very fortunate to have her background as a nurse leading such an important project. And I will now turn the conversation over to Natalie Tappy.
Thank you, Dr. Mims, and again, welcome. I wanted to also introduce our other speakers for everyone today. We first have Janice Hidalgo, who leads the iPro Center for Healthcare Consumer Engagement for the QIO in New York. We also have Brenda Ortiz, who's a program manager with TMF Quality Institute in Austin, Texas. Our last presenter will be Artis Reed, who is a certified diabetes educator for the Health Disparities team at TMF Health Quality Institute in Austin, Texas. Now we'll begin our presentations. As Jen said, today's topic is the overview of the CMS Diabetes Disparities Reduction Program, Everyone with Diabetes Counts. Today we'll accomplish the following objectives during our time together. We will begin with an overview of the CMS EDC program, how we are evaluating our success in reaching our goals, how our partners and stakeholders are supporting us and continue to support us. We will review some methods we've used to teach classes, barriers and lessons we've learned, and lastly, how to become a certified diabetes education center. I just wanted to briefly give a startling statistics from the ADA regarding the cost of diabetes. The ADA estimates that the total cost of diagnosed diabetes has risen to $245 billion in 2012 from $174 billion in 2007 when the cost was last examined. This represents a 41% increase over a 5-year period. Most of the cost for diabetes care, if you'll notice, 62.4% is provided by Medicare and Medicaid. So with the rising costs, we can now see why this program or this project is so important. I'd like to briefly give you the, I think I went too far. There we go. The overview of CMS Diabetes Reduction Program, or EDC. Historically began 7 years ago as a pilot in Florida. It's now the largest national diabetes education program. Its goal is to improve health literacy and quality of care among Medicare beneficiaries with diabetes in minority vulnerable populations. We want to empower people to be advocates for their own health care, to be able to go to the physician and say that they want to know about their diabetes and how to care for themselves. We do this by encouraging diabetes testing in the most vulnerable population by improving the frequency of testing for A1Cs, eye exams, and lipid profile. We actually want to improve the clinical outcomes for these diabetes measures. I'm sorry, Jim, it keeps going forward 2 slides. The overview of the CMS EDC is to recruit and educate physicians whose practices include Medicare beneficiaries with diabetes who are members of a minority and/or rural population on the availability of DSME, which is the Diabetes Self-Management Education Initiative. And we also want to enroll and recruit and teach Medicare beneficiaries using evidence-based programs such as DEEP, which is the Diabetes Education Empowerment Program, the Stanford Program, or Project Dulce. All the classes are taught in the community include cultural competency components. How we recruit sites, we go out to the physicians, we ask them if they want to be participants in this important project. We recruit these beneficiaries through physicians' offices, senior centers, health fairs, community partnerships, like a grocery store, a pharmacy, a school, churches, anywhere that we feel that we will be able to reach these Medicare beneficiaries. We want to go out and ask them to participate. We want to train community health workers, be a part of community health worker organizations. We also want to look at becoming involved with certified diabetes educators, promote diabetes educators, since there's not a whole lot of them throughout the country, be able to encourage more people to become certified educators, and also form partnerships with community businesses. Currently, for the 10th scope of work, we have 3 states that were awarded the contract in 2012. Those include West Virginia, which is the rural population, New York, which is the Hispanic Latino population, and Texas, which is the African American population. So I'd like to tell you a little bit about West Virginia. Briefly, we were chosen in October of 2012 to become part of this special innovation project sponsored by the Centers for Medicare and Medicaid. And what we are doing is actually teaching diabetes self-management education to Medicare beneficiaries. These, if you will look, the counties in West Virginia, the dark blue counties are actually the original 13 counties that we started with. The ones in the light blue are those that we added later on in the years because we were having some difficulty actually reaching these folks, and I'll get to that when I talk about barriers and lessons learned. Within those counties, we have 9 registered nurses teaching the classes. They serve as the master trainers in diabetes self-management education using the DEEP, which is the Diabetes Empowerment Education Program. So we go throughout all these counties, set up our classes, and teach diabetes self-management. Now, some of the barriers and lessons learned, this is in particular to West Virginia. We have the fatalistic attitude. My family has the sugar, so it's only a matter of time. Anger is a problem that we have a lot of times, especially for the elderly. An example would be, I've been eating this way for 80 years. You're not going to tell me what I can and cannot eat now. Religious reasons, access to affordable, nutritious food. One of our main barriers, especially this winter, was the mountainous terrain, because some of our nurses have to travel over 2 hours just to teach class. A lot of times there's no public transportation in the most rural of our communities. Weather, as I mentioned before, was particularly daunting to us in West Virginia. A lot of our patients do not have access to quality health care, lack of support from the medical community. Some of our community support is minimal. And in West Virginia, unfortunately, community health workers are not compensated. But we did learn some valuable lessons, and those are always assess your audience when you're teaching. Use low literacy materials as an example if needed. you want to continually engage your participants, encourage participation when teaching by using demonstrations, games, role-playing, flip charts, models. Prepare for questions because, especially for West Virginia, over 60% of those people that we taught never had diabetes self-management education. And remember, persistence pays off. And now I would like to, oh, I'm sorry, there's another slide. Remembering effective advertising. Direct-to-beneficiary mailing was actually our most successful way to get people to attend the class. We also used posters, flyers, TV, radio, news. We also learned not to have class on the 1st or the 3rd of the month because that's when people actually got their checks. So a lot of times they were more interested, unfortunately or fortunately, in grocery shopping, putting gas in their car. They weren't necessarily interested in coming to class for us. And also on Wednesday night, for West Virginia, a lot of people have church, so we never held class on a Wednesday night. We also learned about preparing food from a food bank, how to get people to understand they can stay within their diet by using food only from a food bank. And also we found that churches are hard to access unless you do have a close contact within those parishioners. So here is our contact information if you'd like to get in touch with us. We also have a website, which we'll get to at the end. So thank you for allowing me to briefly go over our project in West Virginia. I would like to now introduce Janice Hidalgo, who's the Director of iPro Center for Healthcare Consumer Engagement Programs. Janice?
Thank you so much, Natalie. At iPro, we've been working on the Everyone with Diabetes Counts program for 6 years now in New York. We have used 2 DSME programs, the DEEP, which is the Diabetes Education Empowerment Program, which is part of the Midwest Latino Health and Research Training and Policy Center. And we've also used the DSMP program, the Diabetes Self-Management Program from Stanford University. In the ninth scope of work, we provided our community health workers with the opportunity to choose the program they preferred. And as a result of their preference in the 10th scope of work, we are solely using DSMP. Our data shows between the 9th scope and the 10th scope of work that there's no difference in terms of patient activation and the results of these between any of these programs. Our community health workers decided to use DSMP only because for practical issues, we're in the city, they take subways. DEEP could be a little bit prop heavy, so it's best if you have a place where you already have your props in place for these classes. And with the Diabetes Self-Management Program, you just need a few charts and your manual. I just want to point out before we continue that, and this is a pet peeve that I have, that self-management is not outreach, and you will learn this once you start, working on the project and understanding why it's so important to make this different. While self-management means different things in different fields, for the purpose of this presentation, this is referred to the methods and skills and strategies which individuals can effectively direct their own activities towards the achievement of their objectives and, depending on their particular issue or chronic condition. This includes goal setting, decision-making, problem-solving, time management, among other strategies and tools that we offer them. So one-time outreach is great. It doesn't mean that, any education is a good education, but it takes a little bit more for somebody to change their behavior. And one-time outreach is great for raising. And the Gerber approach, which is the holding hands, that's not really empowerment. And, we can go through this later on, but I just wanted to point that out. So, ninth scope of work, this is briefly what we were tasked to do by the Centers for Medicare and Medicaid Services. We were tasked to work on diabetes self-management education, and our colleagues from Texas will later explain the difference between DSME and DSMT, which is confused a lot. Our goal was to graduate 2,500 underserved Medicare beneficiaries with diabetes. The focus in New York was African Americans and Hispanics. Where? Everywhere. Senior centers, hospitals, parks, basement, churches, housing buildings, clinics, wherever there was a place where it's a community-based setting and we would go to the consumer, not the consumer to us, that was a good place. And it also needed to be available for 6 weeks because one workshop or session is equivalent to a weekly class of 2.5 hours. So for example, if workshops are Tuesdays, there's all the next 6 Tuesdays at 10 to 12:30 every Tuesday for 6 weeks. How? In New York, we've been very lucky for many reasons, and I will go through the presentation and let you know, but strong partnerships has been the core of our success with local government and community-based organizations. There's just no other way than you can do this. At least here in New York, this is how we've been so successful. And, you know, it's about self-management techniques. That means empowerment, and then the knowledge you gain in these workshops helps you control or manage your diabetes. The challenge in this 9th scope of work for us was that as a study, it was not originally designed to be sustainable. So as with any project that has a funding that is going to end, people towards the end were a little upset because they were being trained and then we were going to move on to the next thing. But thankfully, we had the 10th scope of work, and we were offered, again, the opportunity to continue our diabetes self-management. Again, 2,500, it was our goal. But in this case, our goal was solely with, our work was designed specifically for the Hispanic population. We needed to enroll 6,000 enrollees, where same place, when the same. But the how was a little bit different because now we were experts. Now we know the community. Now we've been doing this for 3 years. So leveraging our 9th scope of work partnership was and continues to be the success. What's new in this scope of work is sustainability. We were tasked to make sure that beyond contract funding, organizations and community-based entities were able to continue to do the work without us. And also, we were tasked to help and report on improvement on clinical measures before the intervention, DSME, and after. And with providers, we're helping them out with DSMT certification, quality improvement, and technical assistance. And as I said before, TMF will be presenting on that later on. So this is a map of, it's a little blurry, but it basically is telling you where the hot red, the chili pepper red is. That's New York City and Long Island and Brooklyn, and this over here is Nassau, and up here is the Bronx, and this is Westchester. So this is the areas that we were focused on because that's where the majority of the people with the diabetes diagnoses reside. One thing that I wanted to clear is, so in the 9th scope of work, it was a 3-year program. In this scope of work, it's just a 2-year program. So you might say, how in the heck are you going to graduate 2,500 people in 2 years? Well, luckily for us, we were able and are able to do that because we already had an infrastructure. And but it doesn't mean that it's a breeze. You still need an army, you know, you need a lot of money to do it. And you also need to make sure that you have the perfect partners in place. So what we have been doing is that we created 3 different teams. Lower Manhattan and Brooklyn is a team. Long Island and Queens is another team. And then we have the folks that work with Lower Manhattan and Upper Manhattan and the Bronx. So this is kind of to show you how we divided the teams and how we made sure that everybody had different goals per quarter, per month, because at the end of the day, you have to meet your goal. And you can't do it, you know, just, you need to plan this. This is not something that happens. This is something that you need to plan in advance. So this is what we're doing, and luckily, and because we've been working very hard, we are on our way to achieve our goals this July. So this brings me to sustainability, because as you see here, we paired an iPro staff with an intern. So we were very lucky in the sense that in the 9th scope of work, we we piloted a 3-month program on sustainability, getting community health workers from community colleges to, well, actually getting the community colleges to work with us by letting us train their community health workers that needed hours in the field in the diabetes self-management program, the Stanford one that we were using. So they can come and get their hours, help us, because with Stanford you do need 2 people, and it's easier to spread the team that way. So it worked like a charm, but we didn't have enough time to see the complete implementation. So the college was able to have a place for their students to do their internship. The students were able to work with us and learn and actually, you know, have hands-on training on, you know, being a CHW. And we were able to use these people with us as partners, and they taught with us, so that meant that we didn't have to use 2 staff members per workshop. No intern ever worked on, you know, gave a class by themselves. They were always with somebody from the staff, and that was actually a requirement from the school. And they got to learn from us, and I would say, I think like 12% of those interns that we graduated went on to continue. We paired them with some of the clinics that we had and continued either another internship or they offered them a job. And the school was very happy about that because they had a grant that was given to them to foster that these students got a job. So that it worked like a charm. So obviously we continue to do that in this scope of work. Let's see. So who's our competition in New York? As I say, we've been very lucky, and I see a couple of questions asking about what are the local governments, and I'm going to go, you know, what are the partners, and I'm going to go through that in a second. Thank you for the question. But, you know, not everything is peachy cream. You also have our competition, which is birthday parties, dominoes, and bingo. I can't tell you how many texts I've received from my staff saying I had to cancel the class today because bingo got in the way, or because they're going to Atlantic City. And those are real things. See, there's nothing you can do about it. It's going to happen. Luckily, the senior centers have helped us in the way that now that, you know, they know that this is an issue, they just don't schedule these activities when we have a class. And if it's already in the calendar, they just tell us, skip that week because you're going to have a low turnout. So that's, you know, one of our challenges. Another challenge that I would like to talk about briefly, and these are pictures of some of our graduates. We do give them a certificate, and sometimes we get partners to provide them with other materials and goodies, like the Department for the Aging. They provide them sometimes with coupons for healthy snacks, or they provide them with a diabetes log book, and we just try to have a few incentives here and there for them. One thing that I do want to say is that, I'll let you see that picture for a minute, that it's important that you understand for program implementation that it's critical that you have some sort of tracking system, and you need, you know, especially if you want to measure, and I'll talk about that in a minute. It's very important that in part of your planning, because this call is for all of you that might be working on this in the 11th scope of work, or you want to, you know, start a program, even if it's a small program in your community or in your organization. And planning is everything. I cannot stress enough how this is not one of those projects that you can say, yeah, let's start and let's see where it goes. It's not going to work. I'm telling you, you're going to fail. You need to make sure that you plan. You need to make sure that you have perfect partners in place, and you need to make sure that you have the knowledge of your community. And I'll go through that in a minute, but I just can't stress it enough, because there's so many good people out there that want to do so, you know, many good things, but at the end of the day, planning is what you know, makes you fail, and It's just a beautiful program that you could do if you just plan it well in advance. This picture for me is everything. The lady that has her hand in her head, she's dancing. This was actually a big graduation that we did in the Bronx at the end of the night scope of work. Very well attended. Over 300 seniors were able to party with us. It was sponsored by one of the radio stations that were very involved in helping us with PSAs and other things. So what has worked? Core partnerships. New York City Department for the Aging, and here I'm answering one of the questions. It just so happened that in New York, the senior centers, there's an initiative for healthy aging, and there's more than 300 senior centers in New York. So these centers were offered the opportunity to compete for innovation centers through an RFP that the city rolled out. So they needed to do evidence-based programs, and we had it, and it was free for them, so it worked like a charm. 73% of our graduates are from these three partnerships over here. Health fair events, 4%, more for awareness and recruitment. Mailings are our second biggest one. We've reached more than 10,000 Medicare beneficiaries through mailings. Radio advertisements, it's good, not for us in terms of scheduling classes, but for awareness and recruitment, and then 2% others. We have not been very successful in New York with faith-based organizations, I have to say. And tips on implementation, just make sure that you have the right staff to do this. Remember, it's not about telling them what to do. It's about conveying change. It's about engaging. So you have to have the right staff to do this. And here I tell you a few basics on staff. And also, you know, make sure you do an environmental scan. Adapt the curriculum as necessary based on what you're doing. And if you need to ask permission, obviously. Decide what's going to be your focus. Is it going to be train the trainer, or are you just going to do your interventions directly to patients? Remember, education, not outreach. Always have a goal and measure, 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 and measure. Make sure that you know what you want out of this program at the end. You need demographics. Do you want to know, whether they change their behavior in eating or not? Did they stop smoking? Where do they live? All of these informations you need to gather before. And lastly, obviously, have fun. Thank you so much.
Okay, thanks so much, Janice. It looks like you're having a lot of fun over there in New York. This is Artis, and I'm representing the first part of our presentation from Texas. And I will advance the slides. Here's Janice's information that is on the slide here in Lake Success, New York. So you know they have to be successful if their address is Lake Success. And so we here in Texas are going to tell you about our diabetes program with EDC and the Texas Impact. We first started this program in 2010 with Salud por Vida. Our focus was on Hispanic and Native American populations, and this not only focused on people with Medicare, but also with Medicaid. And here are the here are the areas where we focused in the state. You can see that highlighted in the state of Texas. And then our current project is called Health for Life, and this is focused, as Janice mentioned, on African American Medicare beneficiaries with diabetes. We initially focused our efforts on these 22 counties highlighted on our Texas map, which only represent about 8% of the square mileage of Texas. However, it does account for almost 40% of the African American population in the state of Texas. Although we originally identified those 22 counties, we found it necessary to expand to other rural and major metropolitan areas. We went into the Dallas-Fort Worth area. Also, we utilized our partnerships from our first scope of work over in San Antonio and the Austin area. What we found were the barriers for education is we found that there's an unawareness of education for chronic disease in our communities, especially with diabetes self-management. And as many of us have said before, we hear a lot, oh, we don't need to know that, there's not much I can do, that fatalistic approach, or the doctor told me to take a pill and that's all I need to do. People also don't realize that they have benefits and that there are programs in their communities. And so one of the big highlights we've noticed is it doesn't matter that you have insurance. Insurance doesn't mean that people are going out and getting education because they're not aware of those benefits. There are some programs out there, but their teaching methods might not be helpful in motivating people and making those lifestyle changes. So we find that it's more successful utilizing the curriculums that we've mentioned already that are more interactive, very hands-on learning versus the didactic approach where you're just lecturing. The barriers are really looking at making sure that your educators are utilizing the adult learning techniques. Transportation is an issue, especially in Texas. 5 miles can be a significant barrier in Texas. Also, in some cases, we have found there are no programs in the counties, or maybe one program per year. So finding support for continued lifestyle changes has been a significant barrier. And we've also looked at the history of our communities. There may still be some barriers impacting their trust in the medical system or their feelings of marginalization and that fatalistic attitude towards diabetes. So we really looked at all these barriers from our first scope of work going into our second scope of work, or first project to the second project, and work building on those. We also found barriers from the medical professionals. There has been a misunderstanding on how to get their patients into a DSME class. Some professionals don't understand what DSME is about or how to refer their patients into a program or to find one that is in their area. Some people, the medical professionals, can be confused on understanding the benefits of focusing on behavior change instead of focusing on the clinical outcomes. And so we want to help them refocus, seeing the benefit of patients working on those behavior changes for long-term clinical improvements. And sadly, there are some medical professionals out there still giving out the wrong information. And I still hear people that are being told by their practitioners that they have borderline diabetes and they don't need to worry yet. So we want to make sure we're working on those barriers. So we started here in Texas at a grassroots level. We looked at each community to see not only who the leaders were in the community, but where we could put our efforts and resources to build sustainability so there would be continued growth and that strength in the programs that we supported. We learned from lessons from our first project and carried those into our second project when we looked at groups to see the strength of their infrastructure, which we found was very important in supporting classes and educators. We found that if they didn't have a strong infrastructure, they struggled on providing classes. We looked at their community health worker coalitions, the training centers out here, the health ministries. We've looked at engaging all these groups, including the professional associations, the Black Nurses Associations, the Dietetic Associations, the CDE Associations. We've looked at and worked with engaging all these groups to help build that network and community engagement. And as Janice mentioned, I wanted to highlight here the difference between diabetes education and diabetes self-management education. There's a lot of different terms that go around. Diabetes education is really an inpatient or outpatient setting. And what I, as a certified diabetes educator, I kind of can refer to it as survival guide. It often is done at bedside or in an outpatient setting where it's mostly handouts It can be combined with individual or group sessions, but it usually is done in a very quick and dirty way where it's 1 or 2 day format, 8-hour sessions, and it's giving patients really that education or information. DSME, it's also known as DSMT, DSME being Diabetes Self-Management Education, Diabetes Self-Management T training. Training is a term used by CMS, so they go back and forth. And now with the new standards, we've added another letter, and that is S for support. So under the new standards of diabetes self-management, it is now diabetes self-management education and support. And in that, it's all at the outpatient setting, and we really are focusing on the AADE7 self-care behaviors, focusing on behavior changes in that curriculum and also in the class environment, helping people build on making lifestyle improvements. The classes are done in combination of individual and group sessions, but you'll find that these are sessions that are done between a 1 and 2 month period of time. And really the focus of DSME is to help people make those lifestyle behavior changes, build on their progress on making action plans. So they build on baby steps and success, and that's when you see those long-term clinical improvements come, because they have time to work with the curriculum, work with the staff, work with networking and that growth to see how their improvements are improving their health. And with that, I'm going to we passed the ball already to Brenda.
Thanks, Ardis. So sharing the results of these two programs, the first one where we targeted Hispanic, Latino patients, we did enroll thousands of people in the classes, and we had over 8,000 graduates with that program. We did target both Medicare beneficiaries and non-Medicare beneficiaries, so it's a little bit different than I think what New York did initially. We did find some interesting information among the class participants that for those that were Medicare, they had an average of 13 and a half years with their diabetes diagnosis, yet had never taken a formalized diabetes education or self-management class. We also focused on building a train-the-trainer model in our state. We trained over 400 new DSME educators, and as Janice explained, the differences between the Stanford and the DEEP curriculum, in Texas, we were able to really provide that train-the-trainer program based on the DEEP curriculum, but we also partnered with organizations that were already using the Stanford curriculum and then helped them expand and support the work. We also recruited physician practices in our state, and we worked on, QI process with those physicians. So some of the impacts we saw, now this is from a very small sample from that first project from October 2010 to March 2012. We did see improvements in better control of A1C and LDLs. Again, it was very preliminary, small sample, but we're hoping to be able to collect more data for our current project. Our current project, Health for Life, as we mentioned, targets the African American Medicare beneficiaries with diabetes. So far, we have over 2,700 qualified participants, and again, that means they meet all the criteria. They are Medicare, they're African American patients with diabetes, and so they do have to self-identify as having diabetes. Currently, we've graduated almost 2,000 qualified participants, and when we look at the data so far in terms of, have these folks ever had diabetes education, about 60% right now are responding no or unknown, and so I think that trend continues to where we do have a gap in terms of diabetes education for patients who need it. Most of the patients that are coming through the program who have not had education have had diabetes for 10 to 15 years. So these are not necessarily all new patients that are coming through the program, which is great. We're glad that they are finally getting some support and some education.
we had to focus on training a whole lot of educators this time around. The African American community that we are targeting in our state did not have infrastructure really to support the Train the Trainer program necessarily. We had to really go grassroots to identify organizations and even down to communities and neighborhood leaders that were willing to be trained to lead the classes. And so we did provide a lot of training trying to identify as many people and educators as we could that were linked or embedded in the African American community. And I echo Janice's comments about it's all about partnership, and it's all about strategic partnership, finding the right organizations that can reach the right target audience for you. And we also engaged 15 physician practices. So the biggest focus of these projects has been on recruiting the patients, again, train the trainer so that you have educators that can provide the classes, and making sure that we retain those patients for the duration of the program. So some of the bullets on what has worked in our state: partnership development, again, echoing Janice's comments. It's all about the partnerships that we can establish in our state. We cannot do this alone. We have very strong partnerships with the State Department of Health, with their diabetes program, with the American Association of Diabetes Educators, American Diabetes Association, and then down to the local level, those area agencies on aging, community organizations, professional organizations, as Artis mentioned, all of the above. We have really focused on recruiting lay health leaders and community health workers. That has worked very well for us. As I said, with our target community this time around, there wasn't very many community health workers that were embedded in the African American community. So we see that as kind of the bigger goal with this project, is so that when we leave or we end this project, that we would have trained more educators out in these communities, and hopefully encourage some of them to go through the community health worker certification process that Texas has. So there is a gap there that we hope that we're helping address as well. Marketing is crucial with these programs. We were lucky enough to find kind of a local celebrity that would lend his image to the campaign, but we also focused on a very targeted campaign. So it wasn't, so much the TV PSAs and things like that. We found a service that actually could do community postering down to the zip code level. So we identified particular zip codes where we wanted to do these grocery store and convenience store posters. These are pretty large, and they're usually placed right next to the front entrance. And then couple that with having a local celebrity on there, it really grabs people's attention. And so it was very targeted to the neighborhoods that we wanted to reach. We also did newspaper ads in niche publications, such as like African American community newspapers, for example. So we did a lot of that. We also do, as we can, opportunities for earned media, where we try to get on health segments, whether it's on TV or radio, and we try to get an educator from that particular community who's working with us to come on out and talk about their program and engage people that way. So again, it's a very targeted marketing, but marketing is essential. And then of course we provide flyers and posters and all kinds of information out to the community, to our partners, and on our website. The other thing that has worked well is developing this training program, the Train the Trainer approach. We always like to say that, our training program starts with the initial curriculum training, but that's only the beginning. Our educators need ongoing support and resources if they're to effectively launch these classes. And so a little bit about ongoing support and networking. We provide ongoing training and education to our educators. So it's not only the curriculum training. We provide, for example, a few months ago, we provided some additional training on diabetic eye disease. And we partnered with Prevent Blindness America to come out and do some of that and provide some tools and resources to the educators. We monitor classes throughout the project, so we do, our staff does not teach classes directly, but we do go out and observe the classes and provide feedback to those educators, because again, that's part of our training model, is that we have to do this, especially with the newly trained educators. We like to link partners together as well when possible. All of this is looking towards making these programs sustainable, right? So any organization that we know could be coupled, for example, with a clinic or a healthcare provider, we like to be able to do that. We also partner educators together. You know, if there's a new educator that needs some additional mentorship or shadowing of a more seasoned educator, that's also part of our training program. We teach our partners that are delivering these classes skills and data collection and how this data collection is important for them to sustain their programs down the road. And of course, they're always interested in funding. And we say, well, in order to do that, you really have to document what you're doing. And as Janice said, you know, we have some wonderful groups out there that are doing some great work, but if they're not documenting and collecting data, oftentimes they struggle with securing funding. So that's one piece that we do work with our partners on. Linking to existing local health initiatives, we always try to not recreate the wheel, but rather join up local initiatives down in that county or for that particular city, and of course the existing accredited diabetes programs and certified diabetes educators where we have them. In Texas, we still have a lot of communities that do not have either a diabetes program or a CDE locally, and so that's a big gap. But it's crucial to partner with these existing programs so that they understand what we're trying to do and that we can cross-refer patients and that we're not, you know, we're partnering with them. We're not competing with them for patients. There's a ton of patients that need to complete education. We also offer, Artis is really spearheading the technical assistance for groups that want to achieve diabetes program accreditation. And she does that through either on-site assessment, and then she has some work groups that meet virtually to do that. And we'd be happy to talk to you about that. That's a whole, almost a whole project into itself because it involves a lot of support and technical assistance and to some extent some training on what is required to achieve accreditation. We have ongoing education opportunities. We had webinar education provided throughout the scope of the project. We just had our last topic last week. Artists presented on a bunch of those. If we're able to, we get external speakers as well. But that's crucial for us to offer those opportunities not only for our recruited practices but also for our partners and educators. And like I said, we do get our educators together for training. These are on-site, in-person, out in our different target communities, and that is just crucial. Again, part of our training program to provide ongoing education and networking opportunities. That's what's really going to help with sustainability. And we use community organizing techniques and, you know, trying to align our project with the interests of the community, and we could probably spend a whole session talking to you about that. Sustainability, important to plan from the start. As Janice mentioned, it's really difficult when this is added on later in the project, but everything we do, every project we've done here at TMF, we try to look at, okay, how are we going to ensure that when we leave this community, this program continues? Again, feedback to the DSME partners is crucial on data and improving their skills so that we're teaching them, you know, how to fish. The first program we did, Salud por Vida, we recently went back and checked with 26 of the partners we had leading classes, and 25 out of the 26 have continued diabetes education, and so that has been very rewarding for us to see that our efforts, you know, have led to longer-term programming. Accreditation, as I mentioned, is a big piece. Artis works on this. This is kind of bullet points on what she does. We have about 31 partners in different stages. This is a long process. It's not something that organizations can do overnight. And so the fact that we've been able to get 9 to achieve accreditation in the last, you know, in the last 2 years has been really rewarding to see that. And it involves a lot of technical assistance to these groups, and all the credit to Artis for working so hard on that. Other aspects, you know, helping those professionals who want to become certified diabetes educators. We really helped boost that number in Texas between 2010 and current. Again, involves a lot of technical assistance, study sessions to prepare for the exam. It's a slightly different approach, but Artis, again, spearheads that and has done a great job with that. This is our website. You can download all the tools and resources that are available for our program, webinars and things like that. So that's pretty much our section. Here are our contacts. We do have Heidi Turpin as well, who can help answer questions. She does all the data collection and administration for the project. So you can contact any one of us. And with that, I'll end there, and thank you so much for your time.
Thank you to all the participants. This is Natalie. I would like to briefly summarize the scope of work for the 11 scope and tell you what exactly has happened cumulatively throughout the and historically throughout EDC. To date, more than 30,000 Medicare beneficiaries have completed DSME classes, and over 1,000 physician practices have participated in the EDC. There's more than 1,500 volunteers that have been trained as community health workers and taught DSME through train-the-trainer curricula. We also have utilized greater than 2,000 ancillary organizations that have partnered with our QIOs to promote and assist hosting DSME classes. The largest number of people educated nationally are utilizing the DEEP curriculum. EDC has posted results to the CMS Pulse website. You can go there and click on the Community Initiative tabs, and it will give you a list of all of these results. EDC was also featured in the 2012 Diabetes Report Card. The ADA did recognize EDC as a promising practice in 2013. And EDC, there's an article published by Sue Fleck and Terrace King for the Centers for Medicare and Medicaid Services Diabetes Health Disparities Reduction Program, pardon me, that is now available. And looking in the future, I just wanted to say this is what is going to happen in the 11 scope of work. We will continue doing Everyone with Diabetes Counts. It is expanding to all 50 states, as well as D.C., Puerto Rico, and the Virgin Islands. It originally was a 3-year contract, but now it's going to be expanded to 5 years, and it will include dual-eligible beneficiaries, as well as beneficiaries with a diagnosis of prediabetes. There is a greater focus, as Janice and Brenda mentioned, on sustainability. It will increase the numbers of certified diabetes centers in the state, number of community health workers, and we need to continue our partnerships with the CDC, the ADA, and the AADE. We also will be, again, continuing looking at our claims data for 10% sampling of beneficiaries who've completed DSME, and also hopefully doing longitudinal follow-up of the beneficiaries over a 5-year contract period. In conclusion, I would also like to say thank you to CMS for all of their support. We do have the government task leader with us on the phone, Sue Fleck, so she may be also able to answer some of our questions as well. But we, in the time frame that we have, I'd like to get to some of the questions if we could. Now, Janice and Brenda have already individually answered some questions, but I can read those questions to you and their answers if time allows. The first question is from Megan Donahue. Can you give me more information about what you mean by religious reasons as a barrier? And that I'll take that question because that was basically what I had in my slide. Briefly, I can tell you for West Virginia, we do run into a lot of problem when we try to encourage people using faith-based organizations. As I said before, we never hold class on a Wednesday evening because church is always on a Wednesday evening. A lot of times we meet resistance in that people say to us, well, it's all in God's hands. Whatever will be, to use a cliche. And we hope that we can overcome that barrier. But in a lot of our rural communities, it's very difficult to get into the churches unless we know someone. We do get good turnouts when we do because a lot of times our churches are our only community gathering place for some of these most rural of counties. And I hope that answers your question. Question from Kimberly Mueller. Can you please comment on your respective FTE allocation and numbers of provider practices and clients recruited? Trying to understand the level of effort and scale of intervention. I'll send that question to Janice, if she would, please.
Thank you. It's a mix of things. There's no perfect formula. It's going to depend on what your target population is, what is the area in your state that you are reaching out to, and what is your goal of people that you want to educate. Typically, given that we've done here DEEP and Stanford, I would say ballpark you have to multiply the amount of people you want to train, probably between $250 and $300 per graduate. That will give you a ballpark, at least for us in New York. Remember, here is a little bit higher, and that includes the materials, the people, the hours, the community health workers, the trainings. You know, there's a lot that it involves. Separately, I can help you out with that if you want me to, but I would say between 250 and 300, it's a ballpark per graduate. And again, includes hours, data collection, and all that. It might be higher for other states or less, but that's the immediate ballpark that I can give you right now.
Thank you. From Carmen Gonzalez, we have a question. Which nonprofit groups help most with recruitment to achieve your impressive numbers? Janice, again, I'll go to you. I'm assuming that's who she means.
Yes, and I answered it, but I will answer it for everybody else. Here in New York, it was, and it continues to be, the New York City Department for the Aging Housing Authority. And last but not least, you need to reach out to your American Diabetes Association chapter. I'll briefly say something that helps us in New York a lot, which is to assess the group that you're going to be teaching. The American Diabetes Association has curriculum in place, but they're 1-hour sessions. It's not self-management. It's just a 1-hour session on a particular subject about diabetes. So it's a 45-minute session. It starts with a one-on-one on diabetes, and then it goes to heart disease, or it goes to eye care, or it goes to foot care. So we partner with them, and we use their 45-minute sessions to enroll our participants and lure them, because that's the word, to continue our 6-week self-management class. And that really helped them motivate, because they know us, now they know what to look for. They kind of, form this attachment to the person that is teaching, and will come back hopefully for our diabetes self-management program. You have to be very creative. We're happy to help you out.
Thank you. Brenda, if you don't mind, there was a question that was asked. I know you answered it online, but if we could share with everyone, because I think it's an important question. From Marcy Butcher, one of the questions was, are all of the curricula approved for diabetes education program accreditation recognition by ADA and AADE? I'm sorry. Brenda?
Right, okay. Yeah, so the curriculums are not, automatically approved for diabetes accreditation, because really that process involves a lot more than being just the curriculum. And so we always tell our partners, the curriculum does meet all the topics that need to be included in a DSME program, but there's also a lot of other criteria that program has to meet in order to apply for accreditation. I'd like to bring in Artis on that if you want to weigh in, Artis.
Yeah, I always tell our partners, it's not the curriculum that becomes accredited, it's the program that becomes accredited. So when you're looking for the curriculum to use for an accredited program, you have to make sure that the curriculum is covering the topics that are listed in Standard 6. And so you check off, you have a little checkoff list, and you want to make sure that all those topics are covered. And as Brenda said, it's looking at your complete program and how you're addressing those standards. That's based on whether or not your program becomes accredited or not. So it's not the curriculum that becomes accredited, the program that becomes accredited. So when people ask, is that curriculum approved for accreditation, you're not going to get that curriculum is approved. It's the program that's accredited, not the specific curriculum.
Yeah, this is Janice. I just want to add to that, Artis, that this is not to be confused with the curriculums that CMS is allowing the QIOs to do in the 11th scope of work. That has nothing to do with the accreditation process.
Correct.
Yeah.
Right,
okay.
correct.
Yes.
Yeah.
Thank you for clarifying, Janice. Jen, do we continue with the questions since it's at 1 o'clock, or?
Hi, it's Dr. Mims, and I did want to thank everyone joining the call today. We will have the presenters stay on to the line to answer further questions, but to be respectful of your time, we did bill this from 12 to 1, and so if you have to leave, we do understand. But feel free to stay on as our presenters will continue to answer questions. If you leave the event, you will get an evaluation that will pop up, and then you'll be also directed to our website to fill out an additional evaluation for CME planning. So thank you all for joining us, and we will be having an additional presentation on the third Wednesday next month on PCMH collaboration and facilitation. So I will turn it back over to Natalie Tappy to continue with the question and answers. Thank you.
Thank you, Dr. Mims. We do have another question, and this is from Mark Gottlieb. I've been a monitor of the Stanford Self-Management Educators listserv, and one of the unsolved issues is how to organize sustained self-management classes in rural population. I work in 3 states that have a population density 10 to 50 times greater, I'm assuming, than West Virginia. I guess I will answer that question. For us in West Virginia, it has been particularly helpful to, as Janice and Brenda have said, to form your partnerships to make sure you think out of the box. How can you get the people to the classes? Unfortunately for us, again, we don't have a lot of communities that have transportation. We don't have buses. We don't have cabs. So we have to think out of the box how to get these people to the classes. Can we utilize the senior center buses or the nutrition center buses? Can we travel to where they are, to the churches? That's another reason we try to use the churches in the rural areas, because that's the sense of community within those small towns, those small rural areas. So we ourselves use the DEEP, we have to find a way to reach those people, and basically whatever means possible to get. We've had people that walk to our classes. We've had people pay people to drive them to our classes. So whatever ways you can think of to get people to classes is what you have to do. It's very difficult, I know, in the rural areas. Again, also, you said you're from Montana, with traveling. That will be a problem. You know, hopefully you'll be able to find local areas or local churches or schools even. We've used actually grade schools to hold some classes. They've graciously allowed us to have classes within the grade schools if there's no community center or if there's no centers on aging or nutrition centers. So we've had them in schools. We've actually had them on top of pharmacies where they have a small conference room. We've had classes there. We've, like I said, formed partnerships with most of the hospitals, the physicians in those really rural areas to get the buy-in for the people.
This is Janice. I just want to add something to that. Check into your area on aging agencies, the AAAs. The AAAs have been working with DSMP, with Stanford, for a very, very long time. They're very strong proponents of it, and they also have funding to do that. They also have the partners. So I strongly suggest that you immediately contact the Department of Health, or if they have an aging office, contact your AAAs, contact the ADA, and in rural areas, what I feel is the best way, the best approach probably would be to try to follow and establish a train-the-trainer model where you, and I answered this before to somebody else, where you train your community-based organizations. You're going to have funding to do training, so you train them, and in return, they give you back data, and they give you back anything that CMS is requesting for you to collect data on. And we've done it that way with just a few organizations upstate New York. It has worked. I do have to say it's been very little, but I think that you guys should look into that for rural areas, trying to do the train-the-trainer approach, which means you train an organization to do the training without you. They go ahead and they facilitate these trainings, and they give you back that data that you need. And yes, there's PHI and all of these things involved, but you obviously have to make sure that those things are in place before going forward. That's my.
Thank you. I did want to add too on also, unfortunately for us in the rural areas, we don't have an ADA here in West Virginia, so we can't utilize that, but most states do, but we can't utilize that organization. But for us also, a problem has been trying to get people to do train the trainer. We just don't have the interest. We have to bring in people to teach the classes. We haven't had a lot of outside interest in the most rural areas, especially, to do train the trainers. I just wanted to add that little, because West Virginia is a little bit unique in some of the areas similar to maybe Montana, in that it's really, really rural. One of the questions from Erica is, thank you, Janice, I'm curious about what you are measuring specifically, and I'll turn that to Brenda, please.
So measuring specifically for the DSME program, we do have a pre and post patient activation survey. It's really an attitude survey to determine, did their behavioral intent change, from pre and post the class. So we do have that. We are also trying to collect, for a sample set of patients, some clinical data to see, does this have an impact on outcomes, 6 to 9 months post the class. And so that, as I mentioned, is very challenging when you work with community-based organizations, and it involves a lot of legwork in trying to, get those records from the physician practices that these patients have. And so it does involve other processes, like we have to get our patients to sign a medical release form, there's paperwork, and so the whole data collection thing comes into play with our classes to be able to then collect the data from the patients and show, the results. And so I did want to add that to Janice's comments about the Train the Trainer program. We do have to, during the 3-day training we do for the DEEP curriculum, we do include a portion of the day to talk about the data collection piece. So we do include that in every training because, we need to teach our educators what information we want them to collect and the reason why and how this will benefit not only our program or for what we have to do, but it'll benefit their program. At the end of our project, we do feed that information back to the DSME partner, and that's important for sustainability. And then we tell them, here's your data, and now you can use that as you're applying for funding down the road. So again, echoing Janice's comments about funding, trying to find organizations who do have funding to, to help with the whole data collection and DSME class. We are asking a lot of these educators to collect these measures and to teach the classes. And so it is difficult to get volunteer educators. Not impossible, but it is difficult. And so, you're finding a funding stream. But if you do have funding and you provide them funding, teaching them how to sustain the effort beyond the funding. So we always have that end goal in mind. Sorry, I know that's a long answer to a simple question, but we do collect a lot of measures from the patient.
Could you briefly tell the panelists what the measures are that we are collecting?
Yeah, we are looking at A1C, and we're looking at lipids, and we're looking at eye exams. So was the patient referred for an eye exam? Those are the 3 that we're wanting to see if the patient, utilization rates improved on those, and also, do we improve A1C levels down the road?
Thank you. If our CMS representative is still on the phone, we do have a question I can direct to her from Margaret. If CMS has to approve the curriculum for other than DEEP DSME programs, approximately how long will that approval take? Example, more like 6 weeks or more like 6 months?
Hi.
If Sue is on the phone.
I am on the phone. Can you hear me?
Yes, thank you.
Okay, great. Thank you, Natalie, and thank you, everyone, all of our presenters. This was terrific. The 3, if you look at the scope of work that came out in the RFP, there are 3 identified curricula which the presenters today have given you. if you have an existing program that's successful in the state and you feel that you want to partner with them, you have to submit the information about that, and it has to be evidence-based. So I know in Texas we ran into this, I think, Brenda, it was Gateway, I think, that you wanted to use in the last scope of work, and it was not in the contract. So they went, Brenda went back to Gateway and got the information we needed in terms of how long they've been using the program, just a little bit of information about the program, any evidence they have to say that the program is successful, submitted that to me, and then we review it. The time frame for turnaround, I'm trying to remember, Brenda, maybe it was a week or two? I mean, it was very quick.
Yeah, it was fairly quick. I would say
we don't hold that up. Yeah. Yeah.
Thank you, Sue. I think there's another question, if you wouldn't mind answering, also from Margaret. If a local DSME program accredited by ADA or AADE is interested in partnering with our QIO for the EDC project, and they would like to provide DSME for identified EDC clients, but they don't wish to alter their accredited curriculum to either DEEP or Stanford, is it possible to partner with them for EDC and have that education count for the project? I think you touched on it a bit, but if you could elaborate, please.
Yeah, I think I did kind of answer that in the, but I'm trying to just think of the differences between the first question and the second question. So if you want to partner with them and they are not using one of the three identified curricula, again, it would be the same process. You would have to get the curricula that they're using, some information about it, a little history about it. Is it evidence-based? Any information that they can give you and share to say the success of it? How was the curriculum developed? How long has it been in existence there? You know, that type of information, and give it to me, send it to me as the GTL. And we definitely can go over this at the beginning of the 11 scope of work after the contracts are awarded. Definitely can go over this process, and then I will review it and probably have a few questions for you, but the turnaround is as quickly as possible. We don't want to hold anything up. We want all of you out in the community. It's pretty evident from today's presentation, this is a 100% community-based project. So we want all of you out in the communities all the time as quickly as possible. So there's no holdup. The other thing is, for those of you who don't know me, I've been the GTL for EDC since its inception over the past 7 years, and we'll be going into the next 5 years with it, with all of you. So I usually can evaluate things a little quicker. I'm not new at this. I think the current EDC QIOs can tell you about that. I try to really get everything out as quickly as possible. And I will try to work with you on the different types of curricula. I realize that we're going to run into this, and we don't want to go into a community and push out an existing curriculum. So that's the worst thing we could do. So we have to see, and we do usually take it on a case-by-case basis. You know, it's going to happen. Fortunately, in Texas, it was successful. We were able to partner with them and with Gateway. So,
thank you, Sue.
Is that helpful? I think I'm answering that.
Yes, thank you.
Okay.
I just wanted you to go over it a little bit more because she did ask 2 questions, so I thought maybe helping you might help answer her question. One other question that I wanted to, Janice already answered it, but I think it would be important for Brenda also. One of the questions from Kim is, are lay health leaders paid? And Janice responded that for community health workers in New York, they are paid $15 an hour on average plus transportation. West Virginia, we do not have any reimbursable community health workers. So I'll ask Brenda to comment on that if she can, please.
Sure, sure. And it's very similar to New York. So on average, $10 to $15 per hour plus mileage or other related costs for community health workers. Some of the groups here do provide a stipend format for that instead of an hourly wage, but really we're asking a lot of these educators to you know, invest some serious time into the program. So funding is an issue.
Thank you. One question for Sue, I believe. Marcy asks, I work in Montana. The rural issues are huge. Classes are tough due to the agricultural nature of the work. Is there an allowance for other options in teaching? Example, telehealth, real-time visual, audio options for classes, and is it reimbursable?
We have not done EDC. We tried a little bit of a pilot in Mississippi in the 9th scope of work using some audio equipment. What we did find, though, is there has to be a person on both ends of the audio. So in other words, whoever is running it and teaching it, and then there has to be someone in the classroom on the other end. So there still has to be an instructor there to collect all of the information that we need and the data that we're collecting, the survey that Brenda has mentioned and people have mentioned, that type of thing. So I'm not sure how much time or staff people you'll save by doing that. We're not opposed to it if you can find it. But in terms of reimbursable, we did not pay. This was the University of Mississippi who actually let us use their equipment. We did not pay for the use of it. So you would have to work that out with partners in your state. We also found, though, one of the lessons learned was because this isn't a senior, older population, when you just have that camera on and you're teaching to them, sort of at them, and no one is in the room with them, it's not the same effect. Adult learning theory, it's a little different from when you're teaching college kids who can learn that way a little bit better, or online degree. Most of these people are over 70, so keep that in mind in terms of how people learn. But I don't have any problem if you want to try to pilot it and see in certain areas how it would work. I know the rural areas are particularly challenging. This was the first scope of work in West Virginia that we focused solely on a rural population, and as Natalie has said, many challenges came up, but we need to go forward with that and keep moving, because that is a population that has been pretty much ignored in a lot of this, and we don't want that to happen. So you will run into challenges. We'll probably be doing a lot of brainstorming calls about that as you go along. I don't think there's any way to 100% prepare for this, just as much as you can anticipate, and then we'll have to take each challenge as it comes.
Okay.
I don't know. Does that help? Is that?
Yes, thank you.
Yeah.
Definitely. One question for Janice. For the grassroots, well, also Heidi too, Brenda as well. For the grassroots approach, it was mentioned that groups with strong infrastructures are necessary to support classes. What is considered a strong infrastructure? Janice, please.
You have to make sure that these grassroots organizations have reach in the community. You have to make sure that they know their audience, that they have been successful reaching to your target population already, and because that's solving half of the problem. You need the training and the DSMP and the deep that comes after. You can be trained on that and taught how to do that, but you need to have grassroots in that community. So that's one of my requirements when I'm enrolling community health workers, that they need to be from that community, that they already know and can engage the patients, and that they know that we're around the community, because it's a peer-to-peer education. Remember, this is not a program where it's clinicians teaching patients. This is supposed to be peer-to-peer. And in some cases, you will have students doing it, but in the majority of the cases, it's peer-to-peer. And with that, I leave it to Brenda.
Yeah, no, I agree, and that's why I said strategic partnership. We really have to make sure that the groups that we engage do have that reach into the community. Often if the group is not, say, collecting data on their community, they may think, yes, we do reach this particular population or this particular neighborhood, but once they launch the classes, in reality they find that they don't have that relationship built with that community. And so we have gone through that experience with several groups, and so that's what I'm saying. They need to have a strong infrastructure, that they're embedded in the community, they know their audience, they've had some experience in delivering some sort of programming with this audience, not necessarily diabetes, but that they are a familiar group to that community, and that they can support the educators that they bring into the project, that they can process the data collection forms and submission to TMF. So they do have to have some experience with just these community education types of programs.
Thank you. Janice, there's a question for you, please. Do I understand, this is from Marcy, do I understand from a previous question by Mark that the Stanford online program can be used for folks in a very rural area? How do we verify utilization of the program and follow up with these folks?
Yeah, I emailed. I should.
I'm sorry.
Oh no, that's okay. I'm gonna send the link to everybody, to all the participants for Stanford website. I'm not very familiar with it. I do know it exists. I'm on the listservs for Stanford. I get all of these emails, and I know it's being successful. I imagine that there has to be some sort of way to track attendance, and if not, you would have to develop it. It's one of the tools that Stanford is now. I think that they've been testing it for over a year now, and it's working. So, like with anything else, all of these programs, you can adapt how you implement them in your own community. So you would have just to figure out a way to track that attendance and to make sure that people are attending, because you know, for us in the CMS QIN world, in the 11th scope of work, you're going to have enrollment forms, you're going to have attendance to track, you're going to have demographics that you're going to have to submit to CMS as part of your deliverables. So all of those things need to take place if you're going to, you know, use the online route.
Thank you. Sue, I have a question for you from Mark. Is it possible to clarify exactly what the CMS criteria for rural will be in the 11 scope? There was some ambiguity in the RFP.
I think that's a flat question.
Yeah.
Pardon me?
That's me. That is what she's saying, right? Yeah.
Yeah.
I don't. We don't have specific in the RFP. Actually, we just revised or modified some. I think the scope of work isn't officially out, just the RFP scope of work is out, but the contract award, when it comes out, we tried to clarify some things. I believe it was the Census Bureau definition from 2010 of rural populations. We're using the Census Bureau definition. So as long as you're considered a rural area under the Census Bureau, then we would count that as rural. I think that's what you're asking. Other than that, there's no definition in terms of race or ethnic background. If you're working with a rural population, it doesn't matter if it's white, black, Hispanic, it doesn't matter, as long as it's designated rural by the U.S. Census Bureau. Okay. So I think that's it. One of the things, though, I did want to point out, and this was someone else's earlier question about community health workers, some states do have organized community health worker programs through their State Department of Public Health, and some don't. So you're going to run into areas where, and West Virginia is one that doesn't have any, but Texas has some, and New York has some organized coalitions. We do in Massachusetts have one that's very strong. We have a charter. It's through the state. Rather than reinvent the wheel, things like that can be shared. You can approach different political figures in your state, the State Department of Public Health, see if they're interested in working, you know, toward that. Not that a QIO would develop that, but just sort of plant the seed. That's all part of sustainability in a state that doesn't have infrastructure, to sort of think along those lines, because community health workers really are needed in these areas, and particularly in rural areas. We think there's a huge need, and most of those areas do not have community health workers. So you could be very instrumental in helping develop some of that in terms of sustainability. Just another area, along with, you know, developing more CDEs in the area and things like that, but look at the big picture. And the other thing was, people have used very successfully in this scope of work local celebrity endorsements. So I know that wasn't mentioned during this, but we've had very good luck. I think, Janice, there was a salsa singer. Texas used a football hero and a local football hero, and I think, Natalie, you have, was it American Idol he won or something? America's Got Talent. So we've had, in terms of marketing and recruitment at the local level, if you can find anyone locally who would either has an interest in diabetes, has it, or has it in the family, and is willing to work with you, we do not pay for those endorsements. This is a charitable, you know, they work with you as a partner. Just like you don't pay your partners, they would become a partner with you to help lend, you know, something to the name for EDC so you can mark it. Just to sort of think about that a little bit too, and maybe identify some of those people in the state. Now, granted, this can't be someone, this has to be someone with no conflict of interest. You have to be, I realize, careful about who you identify, but just to think about it, and you can talk to these 3 QIOs about how they went about identifying their local celebrity person.
Thank you, Sue.
Sure.
I do have another question for you from Mark also. The glossary said rural was less than 50K, but the RFP said the census definition, which is not just less than 50K, but also less than 2.5K clusters in urban areas.
We're going by the 2010, the last latest scope of work I saw was the 2010 U.S. Census Bureau definition. So if the U.S. Census Bureau is identifying both, we'll use both. It's whatever the Census Bureau defines as rural.
Thank you.
Yeah, and we can.
I just want.
Oh, I was going to say
sorry, go ahead.
We can talk a little bit more about that after contract award as well. I don't want to get into too much contractual issues right now.
Okay.
Before they're awarded.
I just want to say thank you to Brenda. She has to leave the call. She has a meeting, so thank you again to Brenda.
Sure,
would you like
my
me to?
Pleasure. It's been my pleasure, and Artis and Heidi will stay on for any other questions.
Okay.
Thank you.
And
I have a question. Oh, I'm sorry. There's one more question. Would you like me to go ahead?
Please do.
Okay. For Janice, would Life with Diabetes by ADA and IDC's Type 2 Basics be curricula that would be approved by CMS, since these curricula are both pre-approved by ADA and AADE, which are deemed bodies by CMS? Maybe that's a Sue question.
Yeah, but I want to clarify something before Sue goes.
Okay.
This is actually a good question because and this is natural. I mean, we had all these questions when we started. There's a difference between diabetes self-management education, when you want to call something self-management. There is the DSMT, when clinician is the one providing the education. And then, you have all these one-session diabetes education programs done by the ADA, like American Heart has theirs too. But what you need to understand is that regardless of what the AADE and that's why I said earlier, regardless of what you need for accreditation to become a diabetes center of excellence or to request reimbursement from CMS for DSMT for reimbursement, diabetes self-management, what we do in the community, it's separate from that. It's just that in these contracts, CMS wants us to tackle every single angle because it's the best for the patient. So regardless of whether those curriculums or education programs are used as and approved for DSMT reimbursement, diabetes self-management programs need to comply with goal setting. They need to be in the community, mostly peer-led. They have to have problem solving. Look for the definition on what a evidence-based diabetes self-management program is, and then those are the criteria that CMS will be using for approval or denial of a specifically curriculum. I just don't want people to mix it that if the AADE or the ADA has not approved a specific, or has, because they can approve, I don't know, the 6 sessions that the ADA has on X topic for that specific accreditation. But that doesn't mean that it's self-management, because that could be led by a clinician. So there's a fine line, and as we all start this in the next scope of work, we will learn more about it. But you guys have to research a little bit more on that, and I'll be happy to answer more questions later if you drop me an email. Sue.
Yeah, thank you, Janice. Yeah, there is a distinction. Just because, as Janice said, it's accredited or approved by one of those organizations doesn't mean that that is what we're trying to do in your contract. Initially, the DEEP curriculum that we do use was written to go over 20 weeks because they feel that's how long it takes at a minimum to affect people's behavior. We were able to negotiate that down with the DEEP authors to 6 weeks for our contract purposes. So that is pretty much the lowest we would go. Now, AAD may say, or ADA may say, well, this is 6 sessions, we certify this. But is it really getting at behavior change? Is it really going through the steps, like Janice said, of goal setting, of looking at how to change your behavior, modifying your nutrition, modifying your lifestyle, exercise, all of the things that we teach, medication management, all of that is in this DEEP and Stanford curriculum that we use. That's why we say evidence-based, meaning it changes, it's been evidence to change the behavior. So, no, I would have to say just because AADE or ADA endorses it does not mean automatically CMS will approve the curriculum. We'd have to, again, go through the same process, look at it, examine it, how long is it, what are the goals of that program, what are they trying to accomplish versus what we're trying to accomplish. So there is a difference.
Thank you.
Yeah.
I think we've answered all the questions. Actually, there is one more. There's one more coming in. Would you like me to read it? I'm sorry, it just popped up.
Should we cut it off at this one, maybe the last one? Is that you want to do that?
Yeah, that is the last. That is the last one.
We'll make it the last one.
DSME via telehealth is reimbursable now. There would be someone in the room with the participant. We do DPP with with telehealth, and it works very well. Published papers on this.
Can I address that? I think
sorry.
The audience listening, we are getting confusing apples with oranges right now.
Right.
Telehealth is reimbursable. It's a good process for education, working with your clients. However, this project with everybody with diabetes counts is again, as we've all been saying, is really community-based. We're not looking really at reimbursement. In fact, all of the programs that you've listened to in West Virginia, in New York, and in Texas, these are free programs. They are to marry or to be collaborative with the accredited programs. But they are not necessarily are replacing accredited programs or to be in addition to the accredited programs where you're looking at the same criteria for accreditation. So yes, telehealth works and it is reimbursable, but what we're really looking at for the EDC projects are being able to go into your communities and being able to put on improved access to education where we're helping people with diabetes work on behavior, work on action plans so that they're improving how they monitor their blood sugars, so they're improving how they're taking their medications, more compliance and understanding how their medications are working on their bodies. And we're utilizing those AADE7 self-care behaviors. Those AADE7 self-care behaviors are really those behavior changes, improving lifestyles to improve clinical outcomes. Not necessarily are they requirements for accreditation. They all work together, but it's the apples and oranges. So I'm hoping that that makes more sense as everybody's listening.
Thank you.
Yes. We're talking about both in a sense, and actually, and I'm do a lot on the accreditation side here too in Texas. We work with both because not only are we working at the grassroots in our communities to improve access to programs, but also we are improving the infrastructure in the accredited programs, in the community awareness. So there's different levels of this all. But it first starts at the grassroots and looking at what your community has and building that and that community awareness and figuring out as the QIO how to bring sustainability and education to that community. In fact, as we speak, I'm up in the tiny, tiny corner up in East Texas right now, far from Austin, working on it right now. So again, telehealth works, but it kind of, this is my personal hat, not my QIO hat, but it would be pretty difficult to help people with those action plans and that engagement and involvement and interactive communication that we do in all of our DSME classes.
Thank you.
Thank you, Artis.
And I think that's all of. Oh, I'm sorry.
I'm sorry, Nan. This is Sue. That's what I tried to say earlier about adult learning theories, that, you know, we did have a few issues with this in Mississippi when we piloted this telehealth, you know, way of doing these DSME classes. It's a different animal. We're not worried in this project about reimbursing for this particular. You are paid through CMS. The QIOs are contracted through CMS to do this. There is no charge to the beneficiaries or to physician practices who work with us or any of our partners in this. This is a government-sponsored program, separate from what Artis said. I'm sorry, I didn't realize. I'm thinking I'm talking to all QIOs, so I'm not realizing there may be non-QIOs here who don't realize that. So there are distinctions between what we're doing and what is reimbursable out in the private sector. This is a separate contract.
Mm-hmm.
Yes, thank you, Sue.
Thank you.
Thank you, Sue. Thank you, Natalie, Heidi, Janice, Artis, all of you for joining our call today. This has been an outstanding discussion. I mean, really, it's more than what we could have actually hoped for. And having the dialogue among you, having the experts on the phone to be able to help guide all of us nationally as we move forward in this work. I would let everybody know that these slides will be available on our website toward the end of the week, early next week. Please do answer the survey at the end and go online to our website to do the CME. And I look forward to working with all of you in our next statement of work. Thank you very much, and we'll end the call.
Thank you.
Thanks, everybody.